Welcome to Board Pearls. This is episode 1 of 3 of the Portal, Hypertension, and Cirrhosis Complications chapter in the Liver Disease module. This episode is Portal Hypertension and Varices, the hemodynamic gold standard, and the non-invasive thresholds for clinically significant portal hypertension, screening and primary prophylaxis, the acute variceal hemorrhage bundle with early tips, and the gastric varices, portal hypertensive gastropathy, and GAVE distinctions. Portal hypertension is a pressure problem before it's anything else. The architecture of the cirrhotic liver distorts the sinusoidal bed, intrahepatic resistance rises, and the portal system has nowhere to decompress. Then splanchnic arterial vasodilation pushes more flow into a system that already can't drain. The peripheral circulation underfills, the sodium-retaining hormones activate, and a hyperdynamic state takes hold that becomes the substrate for ascites, hepatorenal syndrome, and the pulmonary vascular complications. Every downstream complication starts at this hemodynamic root. The way we measure it is the hepatic venous pressure gradient, taken at catheterization as the difference between the wedged and free hepatic vein pressures, and its thresholds matter because each step predicts a different complication. Over 5 defines portal hypertension at all. 10 or higher defines clinically significant portal hypertension and identifies the patients who will develop varices and decompensation, and over 12 marks the variceal hemorrhage threshold. The reason 10 gets the name clinically significant is that it's the pressure at which the splanchnic bed has reorganized enough that collaterals form, so the patient stops being merely cirrhotic and starts being at risk of bleeding and decompensating. There's also a response definition for beta blocker therapy. A responder is one whose gradient falls by more than a fifth from baseline or to an absolute value below 12, and responders have substantially lower bleeding and decompensation risk, which is the mechanistic reason the medication works, because the pressure drop is the therapy. The framework also splits by where the resistance sits, because presinusoidal and postsinusoidal causes can produce clinically significant portal hypertension without sinusoidal disease, and the management diverges by level. Presinusoidal causes include schistosomiasis, the most common cause worldwide, lodging eggs in the portal venules with periportal fibrosis, idiopathic non-cirrhotic portal hypertension, and isolated portal vein thrombosis. Postsinusoidal causes include Budd-Chiari from hepatic vein outflow obstruction, right heart failure transmitting elevated central venous pressure retrograde, and sinusoidal obstruction syndrome from endothelial injury. The classification matters because each level points to a specific path: anticoagulation and angioplasty for Budd-Chiari, defibrotide for sinusoidal obstruction syndrome, treating the driver for portal vein thrombosis, and for sinusoidal cirrhotic disease, the rest of this episode. The modern non-invasive framework does 2 things that change practice. First, it shifts beta blocker therapy from a variceal detection decision to a portal pressure decision, because a trial showed that in compensated cirrhosis with clinically significant portal hypertension and no high-risk varices, a beta blocker reduced first decompensation, especially ascites. So beta blockers prevent decompensation even before varices form, which is a different indication from variceal prophylaxis and mustn't be confused, since cirrhosis alone without clinically significant portal hypertension isn't an indication because beta blockers. Second, it gives a non-invasive way to detect clinically significant portal hypertension from liver stiffness and platelets, the rule of 5. Liver stiffness under 10 kilopascals rules out compensated advanced liver disease entirely. 10 to 15 is suggestive, and for portal hypertension specifically, a stiffness of 25 or higher rules it in, while a stiffness of 15 or lower with platelets of 150,000 or higher rules it out, with a gray zone in between indicating probable disease. The mechanism is that platelets fall as portal pressure rises because splenic sequestration scales with portal flow, and liver stiffness rises with the fibrosis that increases resistance, so the two together estimate what the pressure gradient would tell you invasively. There's also a screening carve-out that lets you defer endoscopy when liver stiffness is under 20 kilopascals, and platelets are over 150,000, substituting yearly elastography and platelet trending, because that combination has too low a yield for clinically significant varices to change management. Acute-on-chronic liver failure sits on top of all this, being acute decompensation, new ascites, encephalopathy, bleeding, or infection, plus secondary multi-organ failure, with sepsis the most common U.S. trigger, and the prognosis tracking the number of failed organ systems. So 3 or more organ failures carries a short-term mortality above 75%. Variceal hemorrhage is one of the triggers, so a high-risk bleed in a patient already trending toward multi-organ failure benefits most from early intervention. That brings us to variceal screening. Esophageal varices are present in about half of cirrhotics overall, rising with child class, and they grow a few percent a year, with the 2-year first bleed probability much higher for large varices than for small ones, and that gap is what sets size as a threshold for primary prophylaxis, because large and medium varices bleed often enough that intervention pays back while small ones don't. Once a screening endoscopy is negative, the surveillance interval scales with ongoing injury. Repeat in 2 years if injury is ongoing, meaning active drinking, or untreated viral hepatitis, 3 years if quiescent, annually once cirrhosis is decompensated, and 1 to 2 years for small varices. And once a patient is on a beta blocker, no surveillance endoscopy is needed because the prophylactic decision is already made. For medium or large varices, the choice is a non-selective beta blocker or band ligation, with carvedilol preferred over propranolol or nadolol for a mechanistic reason. Non-selective beta blockers reduce portal pressure by cutting cardiac output and by leaving splanchnic vasoconstriction unopposed, both of which reduce inflow, and carvedilol adds alpha blockade that relaxes hepatic stellate cells and reduces intrahepatic resistance, so it attacks both inflow and resistance, while the others attack only inflow, giving a bigger pressure reduction. Dosing follows physiology. Carvedilol starts low and titrates to a modest, twice-daily dose, while propranolol or nadolol titrate to a resting heart rate of 55 to 60 or a quarter reduction, keeping the systolic pressure above 90. For small varices, a beta blocker is added when red whale signs are present or in child C cirrhosis, because red whale signs indicate a thinned wall and higher wall tension at any given pressure, and child C means portal pressure runs high regardless of size. Band ligation is the alternative when beta blockers are contraindicated, done every few weeks until obliteration, and the two are roughly equivalent for primary prophylaxis. The beta blocker hold rules deserve a careful read, because the older teaching that they're contraindicated in refractory ascites isn't quite right. The current guidance is to hold them when the systolic pressure drops under 90, the sodium falls under 130, or acute kidney injury develops, because an already vasodilated cirrhotic depends on cardiac output for renal perfusion, so reducing it can tip into renal hypoperfusion, and you resume when the physiology resolves, so the medication is held, not abandoned. Acute variceal hemorrhage. Any GI bleeding in cirrhosis is variceal until proven otherwise, and a resuscitation is the general upper GI bleeding bundle with 2 cirrhosis-specific layers on top. The splanchnic vasoconstrictor octreotide started on presentation and continued for a few days, mandatory ceftriaxone prophylaxis, and urgent endoscopy within 12 hours with band ligation, with balloon tamponade or a covered stent as a bridge when bleeding can't be controlled, and escalation to TIPS for failures in high-risk patients. The transfusion threshold is the first cirrhosis-specific point and one of the most tested, because it reverses the instinct to push hemoglobin higher. Transfuse to about 7, not higher, because overtransfusion expands intravascular volume, raises portal pressure, and worsens rebleeding, with the trial data showing restrictive transfusion improves survival, so the goal is to support perfusion without driving portal pressure up. The second is ceftriaxone prophylaxis, mandatory rather than optional, because the disrupted gut barrier in an actively bleeding cirrhotic seeds ascites and bacteremia, and the resulting infection itself raises rebleeding and mortality, with prophylaxis substantially reducing infection, spontaneous bacterial peritonitis, and mortality, a benefit large enough that no antibiotic decision is deferred. Now the most important cirrhosis-specific decision in the index admission, early TIPS. In the pivotal trial, patients with high-risk bleeds, child C in the 10 to 13 range, or child B with active bleeding on the index endoscopy, randomized to early TIPS within 72 hours, had substantially better 1-year survival than standard therapy, and the mechanism is that early TIPS converts the failing portal pressure-driven physiology to a controlled shunt before recurrent bleeding drives multi-organ failure. The operational point is that the decision is made during the index admission rather than after the second bleed, because once rebleeding occurs, the benefit narrows since the decompensation cascade has already started. Covered TIPS is the modern default because it thromboses less, and the contraindications all trace to the same trade-off, since the shunt that lowers portal pressure also raises right heart preload by shifting portal flow systemically and bypasses hepatic ammonia clearance. So severe right heart failure or pulmonary hypertension is a contraindication because preload rises sharply. Prior overt encephalopathy is a contraindication because the shunt delivers ammonia-laden blood past the hepatocytes that would clear it. And biliary obstruction is a contraindication because of cholangitis risk. Once the bleed is controlled, Secondary prophylaxis is dual therapy, a beta blocker plus band ligation to obliteration, acting multiplicatively because the beta blocker lowers pressure across the whole system while band ligation eliminates the index column, and neither alone matches the combination. 2 procedural details. Secondary prophylaxis banding is done every 7 to 14 days rather than the longer primary prophylaxis interval, because the post-banding ulcer takes that long to heal and rebanding too soon risks deeper injury, and a proton pump inhibitor for 2 weeks after each session reduces post-banding ulcer bleeding since the defect is acid-sensitive, with surveillance endoscopy after eradication at a few months then every 6 to 12. The gastric varices, portal hypertensive gastropathy, and gave picture rewards thinking about anatomy and drainage rather than appearance. Gastric varices classify by the Sarin system. The lesser curve extensions of esophageal varices are most gastric varices and behave most like esophageal ones because they share drainage, so band ligation usually works. The cardiofundal type extending into the fundus and the isolated fundal type, often with a gastrorenal shunt, sit in thicker submucosa with larger varices, so band ligation can't reliably capture them, and the options shift to cyanoacrylate glue injection or ultrasound-guided coil embolization, with the glue polymerizing. The drainage information drives the choice between TIPS and balloon-occluded retrograde transvenous obliteration. When a gastrorenal shunt is present and other portal hypertensive complications are absent, that obliteration is preferred because it occludes the shunt from the systemic side without modifying portal pressure. While when concurrent complications like refractory ascites are present, TIPS is preferred because it lowers pressure across the whole system. An isolated fundal varices without esophageal varices is the highest yield trap in this space, because their presence in a patient without portal hypertension elsewhere should prompt evaluation for splenic vein thrombosis or left-sided portal hypertension, since the splenic vein courses behind the pancreas and is vulnerable to peripancreatic inflammation or tumor. So most cases come from pancreatitis and some from pancreatic cancer, with the fundal varices serving as collateral drainage through the short gastric veins and treatment being splenectomy or splenic artery embolization, which is curative when the thrombosis is the only driver because removing the spleen eliminates the high-flow inlet and the collaterals resolve. Portal hypertensive gastropathy and GAVE are the second high-yield distinction, looking similar but diverging entirely in mechanism and therapy. Portal hypertensive gastropathy is a mosaic pattern in the proximal stomach whose severity parallels portal pressure, with chronic low-grade blood loss, the dominant pattern, managed by portal pressure-directed measures, iron plus a beta blocker first, argon plasma coagulation for localized bleeding, and TIPS for refractory transfusion-dependent disease. GAVE, the antral vascular ectasia called watermelon stomach, breaks the portal pressure logic entirely, being red spots without the background mosaic, antral rather than proximal, occurring even without portal hypertension, associated with systemic sclerosis, autoimmune disease, and chronic kidney disease, and managed with mucosal ablation, and TIPS is not effective and not recommended, which is the board favorite trap because GAVE in a cirrhotic looks like it should respond to lowering portal pressure but doesn't, since the antral ectasia exists independently of portal flow. So the way of thinking. Portal hypertension is a pressure problem with a hemodynamic gold standard and a non-invasive translation through liver stiffness and platelets. The pressure produces varices, the varices bleed, and the bleeding is managed by a bundle whose cirrhosis-specific layers are the restrictive transfusion target, mandatory ceftriaxone, and the early TIPS decision made during the index admission rather than after the second bleed. Primary prophylaxis is carvedilol or band ligation, chosen by the same principle that organizes bleeding management, lower the pressure across the system, or eliminate the specific column, and secondary prophylaxis combines both. And in the gastric varices, gastropathy, and GAVE space, anatomy and drainage drive therapy, not appearance, with the gastrorenal shunt picking the retrograde obliteration and cirrhotic portal hypertension without a usable shunt picking TIPS, isolated fundal varices pointing at splenic vein thrombosis, and GAVE breaking the portal pressure logic. The next episode picks up the same hemodynamic route and moves it into ascites, the fluid analysis framework classifying ascites by portal hypertension versus everything else, the diuretic ratio anchoring management, refractory ascites managed with TIPS, and the hyponatremia that comes with it, with the organizing question being what to do when the portal pressure that drove the varices starts driving sodium and water retention that no longer responds to standard escalation. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 3 of chapter 23, and I'll see you in the next one.